Up next, Peter McCollugh is joined by Dr. Kathleen Grady, Administrative Director at the Center for Heart Failure at Northwestern School of Medicine in Chicago, Illinois, to discuss what to do for the patient without surgical options.
Kathleen, welcome to ACCEL.
Thank you very much. I'm delighted to be here.
Well, let's set the stage here that heart failure is obviously a very prevalent condition in the elderly. And all the large epidemiologic studies of heart failure suggest that when a patient has that diagnosis, about 90% of the time, their terminal illness is in fact heart failure. And that was shown actually in a large study I published many years ago called the REACH study. That's exactly what we had found. And the issues that have come up in heart failure is when we've exhausted the opportunities for bypass surgery, heart transplantation, left ventricular assist devices, biventricular pacing. So all the invasive therapy is now been exhausted as options. And as medical cardiologists, we're dealing with the issues of how to best manage the patient. So why don't you take it from there and give us a few principles to follow?
The palliative care team has been available to other practitioners, including cardiac practitioners, for a very long time. They are a team that can provide additional care for patients in the realm of symptom distress, caregiver burden, helping patients with psychosocial issues, with pain issues. These patients typically are failing medical therapies. They're doing very poorly. They've been on chronic disease management for a long time, and they reach a point in time where comfort is more important because there are no other alternatives. And so the palliative care team at that point in time becomes a team that can very much assist the patient and family. And believe it or not, although we all know that the patient's quality of life is poor at that time, they have a lot of symptom distress. They are often anxious, depressed, stressed. They're typically socially isolated. They're breathless all the time. They are unable to perform usual activities of daily living, punctuated by times that can have somewhat okay quality of life. And so that's a point in time when the focus should move to helping them with the best quality of life possible as they reach that end stage of heart failure, which can be very difficult to identify. The trajectory is a little different than perhaps, say, the cancer patients who have a fairly steady downward trajectory in terms of their physical function, their quality of life, their survival across time. With heart failure patients, it's not quite the same. The trajectory is often punctuated by times when they're doing a little bit better. There may be some other therapies before they get to that point in time. But nonetheless, there's a point in time when you say it is time for palliative care to assist with the disease-modifying therapies. And then as things progress and things become much worse, then it's time for the palliative care and the comfort and support of the caregiver to really take over, notwithstanding the point that indeed the ongoing disease-modifying therapies are still important.
Most hospitals do have palliative care teams or consultation available, and that it's not just inpatient, but it's also outpatient. So how does a cardiologist in community practice kind of get this activated?
One of the best ways to get it activated is we know these patients with advanced heart failure are in and out of the hospital frequently. And so when they're in the hospital, that's a point in time to ask for a palliative care consult and ask that team to become involved in the care of the patient. And what's very important is that palliative care services are available, both in and outpatient. They can help with the seamless movement of patients from the inpatient to the outpatient care. If patients choose to die at home rather than in the hospital, they can help mobilize community resources, aides. They can provide direct care themselves. They can work in conjunction with the cardiologist in terms of managing these patients. So they are very much available in both inpatient and outpatient settings.
Now, one of the things the clinical cardiologists will be doing in most circumstances is managing the drugs. So I was wondering if you could give us a few pointers. Let's take major classes of drugs. So the first one being diuretics. And the question specifically is, do you ultimately turn that over to the patient and the family to self-manage diuretic dosing, or is that something that should always be physician controlled? How does that work?
I think it's dependent on the program and the physician and the family comfort with managing diuretics. It certainly remains an important part of palliative care at the end of life because patients who are fluid overloaded are very uncomfortable, they're very short of breath, and so obviously diuresis is an important component of care. I think some families are able to manage that, others are not. It depends on a lot of other issues, including health literacy, and so that's really got to be assessed independently, but it is clearly an important part of the self-care. And families should be totally engaged and able to assist as best they can with reliance on the team to help them out.
So diuretics to help improve dyspnea. How about oxygen? Is it usually okay to prescribe oxygen?
If indicated, absolutely. Yes, it is.
Okay.
And inotropes, I might add. In days gone by, it was widely thought that inotropes would decrease mortality. We all know today that is certainly not the case. But inotropes for palliation of symptoms is very important and can be and should be used in both the inpatient and outpatient setting as continuous inotropic support.
In your program, that's done still some home dobutamine or home milrinone?
Yes, absolutely.
And then how about the use of opiates?
They are certainly useful as well when patients are very much at the end of life, and that is often managed by the palliative care team because they are the experts, more so than the cardiologist.
Right. Do benzodiazepines have a role as well in reducing the anxiety around dyspnea?
They can, absolutely, again, managed by the palliative care team.
What about the issue when patients get pretty far along and the fluid retention in some cases can just simply be massive? Patients can be up 10, 20, or 30 pounds. They have ascites and a sarca, and it's an awful situation. Should the cardiologists or the teams venture into this area of hospitalizing the patient and offering ultrafiltration or forms of extracorporeal therapies?
I am not aware of any evidence that supports that. I think by the time that patients are that far along and it's deemed irreversible, medical management and medications to make the patient comfortable are truly where patients are at. If there is much more burden, much more suffering than benefit that might be gained, and you're simply prolonging the suffering, it's not a good option. So clearly in the heart failure guidelines, aggressive therapies at end of life are not appropriate.
Okay. And then how about this whole list of activities that we do that are considered standards of care in a sense for prophylaxis of some other problem? For instance, a patient with heart failure, they have terminal heart failure, but they also have atrial fibrillation and they're on Coumadin. At some point in time, when do you stop the Coumadin?
Oh, good question. I think more importantly, if I can back up, is stopping deactivating the ICD is important when they are clearly at end of life, because that would be a terrible death. You don't want them dying with the ICD going off. As far as other medications, I think that should be a joint decision between the cardiologist and the family, with the palliative care team very much involved and aware of what the potentials might be. But the focus is always on comfort for the patient.
Because at some point in time, backing down on the Coumadin in this prophylaxis against thromboembolic events and potentially backing down on statins because of the idea of preventing episodic atherosclerotic events, and you can go on and on. I think commonly what we face is a patient really towards the end that's hypotensive, that's dizzy. Do you also advise backing down on or stopping ACE inhibitors, ARBs, beta blockers, and these drugs?
We back them down only as far as they affect a patient's, say, blood pressure, for instance. We're not actively trying to hasten death, but it's a matter of supporting them during the dying process. And so if they're on those medicines or they're on stable doses, we don't make any changes in those. We typically just leave them on those medicines and do everything we can to further support patients. Many times they're not tolerating high doses of ACEs. They're not tolerating beta blockers. So those kinds of things are happening already because they're not tolerating.
Right. You kind of already naturally brought those down.
Yes, absolutely.
But my question regarding devices is, what's the accepted community practice, if you will, in this idea of, quote, deactivating an ICD or a biventricular pacemaker? Is it just that the anti-tachycardia algorithm and the shock algorithm is turned off? Or is actually the pacing component of the device turned off as well?
Typically, it's the ICD component, the shocking component, that is turned off. And I think if there's any more than that, again, that's a conversation with the patient and the family. I can't stress enough that patients and families need to be integrally involved in all of those decision-making processes. But by and large, it's the shocking component that is discontinued.
So it's reasonable to leave the pacing part of the device on. So at the very end, in your experience, do most patients actually die at home? Or do they die in facilities, nursing homes, or hospitals? Do you have any sense of this?
It's both. It's all of the above. Patients whose families are comfortable providing care in the home, whose home can be adequately prepared, having a comfortable hospital bed, for example, on the first floor that the patient can be on because you recognize they can't go up and down the stairs, obviously, and having access to community resources, having a palliative care hospice team that's able to come into the home. If that can be done and the patients can die comfortably, then it's important to respect their desire, their preferences if they'd rather die at home. Other times there are patients and families who can't deal with it. They don't have adequate facilities at home. They're fearful. They're afraid that the patient perhaps might die without a healthcare person in attendance. They would be more comfortable in a hospital setting. It all goes back to asking patients and families what is the most comfortable for them. Yet at the same time, we have to be thoughtful and mindful about resource utilization for patients who might have a more protracted course while they're in hospital. How long would those patients be in the hospital? So it's really a lot of conversation that has to happen. And again, the hospice teams can lead that conversation.
At what point in time should we really go after getting advanced directives in patients with heart failure?
Oh, that should be early. That should clearly be early in the process, not by the time they're at end of life with a hospice team, whether they're in hospital or at home. Heart failure, by nature, we all understand, is a disease process that has high mortality. They may die of other causes along the way, perhaps, but nonetheless, with heart failure, once that diagnosis has been identified, it's important at that point in time to at least have conversation about these are the kinds of things that need to happen. A lot of patients do not know that heart failure is a disease process that results in high mortality. They don't know that. They don't know they have a disease or syndrome from which they're going to die. And so it's having that conversation, that dialogue across time. Should be an iterative process, a conversation that happens from the moment they have the diagnosis and then on an annual basis perhaps, and then as well when there are important events that happen like rehospitalization, if they have a subsequent heart attack and their heart failure worsens, whatever the event is, those events should further drive the process, and really patients need to understand, but absolutely advanced directives, power of attorney, all those things should be done much, much sooner than end of life.
Okay. And when the home hospice teams are involved, and generally, how frequently do they see the patients at home?
That would be tailored, obviously, to the individual patient. If it's the physician, it would probably be on a less frequent basis, but the nurses might come on a weekly or twice weekly basis. Chaplaincy availability could vary depending upon, again, patient and caregiver needs, culture, spirituality needs. But certainly, I would say at minimum weekly, and sometimes more than that, depending on the specific care that the team is providing. And it would be the team in consultation with the patient and family, sitting down and talking about, these are the kinds of things we can do. This is our recommendation. And it's always based on provider recommendation. What do you think? What would you like us to do? And so it's really sitting down and coming up with an end-of-life plan of care.
So it sounds like every cardiology office really ought to have in their Rolodex of referrals palliative medicine consultants, hospice and home hospice consultants that either have contracted with their clinic or their hospital or the doctor has a relationship with, so they can call upon these resources and really be prepared with the patient for what is a terminal illness.
Absolutely, unequivocally, without a doubt. The palliative care services, sadly, are not well utilized by cardiologists. And I think some of it is that sometimes cardiologists, they believe that palliative care and hospice is a non-option. I have nothing more I can do for that patient. And so it's not viewed as a treatment option, but it is a treatment option. And it's a treatment option at end of life. And there are times when the cardiologist will do everything they can to continue to treat a patient. And again, as I said earlier, disease-modifying therapies should continue through the end, but the focus may change to more comfort. And so it's important to recognize when enough is enough, and talk with patients and families about that end-of-life plan and ensure that experts in caring for patients at end of life are available to provide the comfort, the support as needed.
Well, this has been a terrific review of the principles of palliative medicine and end-of-life care for patients with stage D or terminal heart failure. Kathleen, I want to thank you for visiting us on ACCEL.
Thank you very much. My pleasure.